create programs that are helpful and informative for you. So if you could please take a few minutes and scan the QR codes. There's one for patients and caregivers and one for healthcare providers. All right, the links are also in the chat, so we will keep it moving because we have a lot of content to cover today. I first want to thank our sponsors, Shar and Viacord. Shar has been a sponsor for many of these sessions at this point, but Viacord's a new one, so I just want to briefly explain what it is. Viacord offers families the opportunity to plan for their future right from the start by giving parents the ability to preserve powerful stem cells from their baby's umbilical cord at birth. In addition to cord blood banking, Viacord offers newborn genetic tests using a sample of banked cord blood to provide parents useful health insights to support their child's health journey. One of those tests is the newborn digestive health test, which can help parents understand their child's predisposition or risk for developing celiac disease or lactose intolerance. So thank you to Shar and Viacord for sponsoring the session. All right, so now getting into the content. So this session is on celiac disease and parenthood, navigating fertility, pregnancy, and breastfeeding. It is approved for one CEU for physicians and dietitians, and there will be more information about how to claim those credits at the end of the webinar. You can also get a translated version of this webinar in Spanish and Portuguese, and you can click the globe icon to get started. Okay, and now before we turn it over to our speakers, I will just briefly introduce them. So we have Dr. Maureen Leonard, who runs the Celiac Disease Center at Harvard Medical School. We have Jessica Lebovitz, who's the registered dietitian at the Columbia Celiac Disease Center, and Vanessa Weisbrod, our very own Chief of Community Engagement and Education, who will be doing the cooking demo. All right, and actually, yeah, before we get there, Maureen, I'll turn it over to you.
Great, thank you. Let me go ahead and share my screen. Okay, so thank you so much for the invitation to speak, and I'm very excited to kick off this webinar by talking about celiac disease and reproductive health. So these are my disclosures. They're not related to what I'll be speaking about today. And the objectives for my talk are really to discuss the current literature regarding celiac disease and fertility, to review pregnancy outcomes in patients with celiac disease, and then to introduce some literature regarding breastfeeding and risk of celiac disease in children. So I have just one slide for background, so we're all on the same page. But we know that celiac disease is a chronic inflammatory autoimmune condition that occurs in individuals who have an underlying genetic predisposition, and it's driven by gluten ingestion. So under the right conditions, ingestion of gluten-containing grains, which are wheat, rye, and barley, activates an inappropriate T-cell-mediated immune response, which results in small intestinal inflammation and a variety of gastrointestinal and extraintestinal signs and symptoms. So for many, many years, celiac disease was considered a pediatric gastrointestinal disorder, which presented between 9 and 24 months of age with complaints such as abdominal pain, diarrhea, bloating, weight loss, and irritability. However, the development of non-invasive and accurate diagnostic blood tests about 25 years ago really allowed for screening of large populations of people for celiac disease, and that led to the recognition that celiac disease can really be triggered to turn on at any age. And today, most adults are diagnosed between age 40 and 60 years, and women are diagnosed 3 times more frequently than men. And large-scale studies have also led to the finding that celiac disease is truly a systemic autoimmune condition that may present not only with classical gastrointestinal symptoms, again, like the abdominal pain, vomiting, diarrhea, but also symptoms outside the GI tract, such as anemia, joint pain, rash, headache, osteoporosis, and reproductive disorders. So several studies have linked celiac disease with a number of reproductive disorders, but there's really conflicting evidence at this point regarding whether unexplained infertility is linked to celiac disease, and so we'll go through some of that data. There is data to suggest that recurrent miscarriage has been linked to celiac disease. And overall, there are an increased risk of obstetric complications, and we'll get into these details, but there is an overall increased risk of intrauterine growth restriction, stillbirth, low birth weight, small for gestational age infants, and preterm birth. So in looking at whether celiac disease is associated with infertility, I wanted to define infertility, which is really defined as failure to achieve a clinical pregnancy after 12 months or more. It may be primary or secondary. Primary refers to the inability to conceive in couples who have never achieved pregnancy, while secondary infertility refers to difficulties in conceiving after previously achieving a pregnancy. It may be unexplained, and that's when no apparent cause can be found, but that's a diagnosis of exclusion. It can also stem from male factors, it may be female factors, or other general causes such as anatomic abnormalities, endocrine disorders, endometriosis, and infections. So looking into whether celiac disease is associated with infertility, a recent meta-analysis reviewed 11 studies and did not find that celiac disease was more common in women with infertility compared to the general population. And you can sort of see the pooled prevalence of celiac disease is, again, that of the general population. However, 2 previous meta-analyses did find an association between infertility and celiac disease. However, some of these both had a little bit less stringent criteria. So in the first that did find an association, patients did not need a histologic diagnosis of celiac disease. And the other meta-analysis reviewed only 5 studies. So overall, the risk estimate of infertility in women with celiac disease really remains unclear due to different methodologies and just heterogeneity across studies. Additional work has really looked at the risk of having undiagnosed celiac disease in women with unexplained adverse pregnancy outcomes. And you can see here that there is an increased risk of unexplained infertility, again, growth restriction, recurrent miscarriage, small for gestational age, and preterm delivery. So this is patients that are having these, they have a greater risk of having undiagnosed celiac disease. But this study and another looked into it a little bit further, and they looked at the results of adverse pregnancy outcomes now in women with known celiac disease. And they found, again, that the risk, if I go back one, you can see the risk is high here in women with these pregnancy outcomes. But in women with celiac disease, it's much lower. But they found overall that the risk of spontaneous miscarriage, fetal growth restriction, preterm delivery, low birth weight, stillbirth, and having an infant small for gestational age was higher in the group with celiac disease compared to the non-celiac disease group. And then they looked at women with treated celiac disease versus non-treated celiac disease. And you can see here that there was, let me bring this up as well, there was an increased risk of having spontaneous miscarriage in or an infant that was small for gestational age. And this other study found an increased risk of C-section delivery in women with treated celiac disease. And only pregnant women with undiagnosed celiac disease and presumably untreated celiac disease were at higher risk for fetal growth restriction, the preterm delivery, low birth weight, and stillbirth. So there are several possible hypotheses that have been generated to explain the link between celiac disease and reproductive disorders. For example, it may be in part due to selective nutrient deficiencies from intestinal malabsorption, such as folic acid, B12, fat-soluble vitamins, iron, and zinc. So taking a prenatal multivitamin is very important, and I know Jessica will tell us more about that. Cytokine-mediated uterine inflammation may also play a role. So here, gliadin, which is one of the components of gluten, can induce the secretion of inflammatory chemicals, which could affect the intrauterine environment. There's a possibility that circulating autoantibodies associated with celiac disease could lead to immune-mediated tissue damage, and that could eventually lead to reduced invasion of some of the cells that are needed to create the pregnancy or inhibition of endometrial angiogenesis. And finally, there's could be that increased intestinal permeability may be playing a role. So it's a hallmark of celiac disease, but it might also allow for translocation of bacteria that could ultimately lead to and some inflammation in the endometrium. So moving on to the infant's risk of celiac disease, again, you're going to hear more that there's conflicting evidence regarding whether birth delivery mode, specifically C-section delivery, increases the risk of celiac disease. So it's hypothesized that having a C-section delivery leads to alterations in the microbiome, which could then potentially alter immune cell function and contribute to loss of tolerance to gluten. But the studies have been mixed. So early on in 2010 and 2012, there were cross-sectional studies that suggested there was an association between C-section and development of celiac disease. But in 2014, there were two large prospective studies that did not find an increased risk associated with C-section delivery. And we have an ongoing study called the CD-GEM study, and we have not yet seen any increased risk with infants born via C-section. Studies have shown that infants born via C-section do have alterations in their microbiota. So they have lowered overall diversity of their microbiota and some delayed or decreased Bacteroides colonization. But these alterations seem to be transient. So they see some variations in the structure of the microbiome, but not the actual function of the microbiome right after birth. And there's data to suggest that by 6 weeks and several weeks later, there are no long-standing significant differences that are seen in the intestinal microbiome due to delivery mode. There is also data to suggest that exclusive breastfeeding might partially restore the gut microbiome. There's work looking into whether the C-section is labored versus unlabored and how that might alter the microbiome. And there's been some research looking into restoration of the microbiome in infants born via C-section. So can they have what that's called vaginal seeding? So they're exposed to the mother's vaginal microbiome right after birth. There's still ongoing work in this area, but what's come out so far is that there's no evidence of a long-term impact on the microbiota with this technique. There's a possibility of transmission of potential harmful pathogens. So again, the theme of conflicting evidence regarding whether breastfeeding is protective against the development of celiac disease. There were, again, early on, some studies that suggested that breastfeeding at the time of gluten introduction seemed to decrease the risk of developing celiac disease or at least postpone its onset. Other studies have been unable to establish whether it's protective, but we do know that breastfeeding influences the composition of the intestinal microbiota in the infant and offers the potential to prevent some or decrease allergic disease. So we've looked at some of these factors related to pregnancy and breastfeeding in an ongoing study called the Celiac Disease Genomic Environmental Microbiome and Metabolomic Study. So it's an observational international study where we've recruited over 600 infants who have a first-degree family member with celiac disease, and we follow them from birth through age 5 or 10 years. And the goal is really to try to identify environmental factors and identify alterations in the microbiome that are happening before celiac disease onset that might contribute to the loss of tolerance to gluten. So to look into this, we collect a ton of data and samples, starting from when a mom is pregnant. So we collect stool in second and third trimester. We collect early stool from mom and infant, as well as breast milk. And then we collect a ton of information from the infant and the family. So we're collecting stool every 3 months from the infant and blood every 6 months to look for celiac disease. And then we ask information about whether they're exposed to probiotics or antibiotics and what foods they're introduced to really every month for the first year and a half. And so we've been looking at some of these early environmental factors and in work in collaboration with Max Manwaring-Mueller, who you can see there at the Buck Institute, and David Furman there, we decided to look at some of the environmental factors in the first 15 months after birth that might influence celiac disease onset. And we looked at over 62 clinical factors in about 400 subjects, of which more than 50 had celiac disease. And what we found is, one, that our data is in agreement with other work that says really having a high risk HLA type or having 2 copies of HLA-DQ2 is a very strong risk factor, is the strongest risk factor for developing celiac disease in children with a first-degree relative with celiac disease. But you can see here, we also found that breastfeeding within the first 6 months was protective against the development of celiac disease. And we found that increased gluten intake, particularly between 7 and 12 months of age, increased the risk of developing celiac disease. We've also been linking sort of these infant feeding types to alterations in the microbiome to try to learn more about how it's changing the microbiome. And we've used this cohort as well to examine breast milk of moms with celiac disease and without celiac disease. So we looked at their breast milk, the microbiome of their breast milk at 7 to 14 days after birth in a cohort of women who are on a gluten-free diet and those who are not. And we found some differences, including those related to several strains and several metabolites. And now what we are doing in collaboration with Dr. Zalmarati, a computational biologist here at Mass General, we are working to try to correlate what we see in the breast milk from moms with microbes in the stool of infants so that we can try to continue this work. So before I wrap up, I wanted to just talk about whether gluten is transmitted through breast milk. So breastfeeding can promote tolerance of different foods to the infant through immunomodulatory substances and facilitating antigen transfer, which is a scientific way of saying there's food antigens in the breast milk, and this can serve as an early source of oral exposure to the infant that can be critical to establish oral tolerance. So we know that research has shown that there are common food antigens found in breast milk, including proteins derived from egg, cow milk, and peanuts. But the frequency and concentration of these dietary proteins in breast milk varies widely. There has been some work looking at gluten transmitted through breast milk, and this was published just last year, using gluten immunogenic peptides, or GIPs. So these are fragments of gluten proteins that are resistant to gastrointestinal digestion, and they're detectable in previous studies in the urine or stool after intestinal digestion. You can purchase these tests online, but here, this study measured whether GIPs were present in breast milk in 96 women without celiac disease and 23 women with celiac disease. And they did find that GIPs were detectable in breast milk, which indicates really that gluten is absorbed through the intestinal mucosa, enters the bloodstream, and is subsequently secreted by the mammary gland. And this suggests that infants are exposed to gluten antigens even before the introduction into their diet. And so more work needs to be done in this area. So to summarize, studies definitely have shown conflicting findings regarding the association between several reproductive disorders and celiac disease. Studies suggest an increased risk of undiagnosed celiac disease in women with unexplained infertility, women who are pregnant with intrauterine growth restriction, and women with recurrent miscarriage. Study suggests women with undiagnosed celiac disease have an increased risk of, again, intrauterine growth restriction, preterm delivery, low birth weight, and stillbirth. And overall, women with celiac disease have been shown to have an increased risk of spontaneous miscarriage in infants that are small for gestational age. Prospective studies haven't found an association between C-section and increased risk of developing celiac disease in offspring. And there's conflicting evidence about whether breastfeeding is protective against the development of celiac disease, and gluten, like other proteins, is found in breast milk. So with that, I'm excited to hear the next presentations and answer questions later in the program.
Great, Jessica. Go ahead and share your slides.
Thank you so much, Maureen. That was such a great presentation. And now we are going to focus on the nutrition side of things. All right. So we want to start thinking about nutrition and healthy lifestyle even before pregnancy. When you start thinking about family planning, that's when you want to consider how you can take steps to optimize your health and improve your fertility. Very simple steps like eating a balanced diet rich in fruits, vegetables, whole grains, dairy, and protein, along with regular exercise, can really make a big difference. You're given this opportunity to fuel your baby's growth and development based on the foods you eat, so you really want to make it count. You can even help reduce your child's risk of chronic diseases, starting with your own dietary intake during pregnancy. Vitamin supplements are recommended for all pregnant women to meet their higher nutrient needs. And once out of the womb, breastfeeding is strongly recommended for those who are able, especially during the first 6 months post-pregnancy. Breastfeeding works for some women. For others, feeding a baby pumped breast milk with a bottle is another very good option. Some women can't or choose not to breastfeed or pump and choose to feed their babies with formula. And lastly, some women choose a combination of feeding methods. This is a very personal decision. Whichever option you choose, you should have support from your OBGYN, your partner, and your family. Much of the nutrition recommendations for fertility, pregnancy, and postpartum do overlap, but throughout the presentation, I'll specify where the advice differs. So during pregnancy, the need for macronutrients, so our carbs, protein, and fat, increases. This helps to fuel your body and supply the necessary nutrients for your child's development. You can see here that for a single gestation pregnancy, usually no extra calories are needed in the first trimester, but as we move on to the second trimester, you need an extra 340 and then 450 extra calories per day in the third trimester. Obviously, calorie needs are even higher for those carrying multiple babies. There are countless studies demonstrating the positive impact of breastfeeding on a child's future health. The ACOG states that the human milk is the most complete form of nutrition for babies. It has the right amount of fats, sugars, water, and protein needed for growth and development. As your baby grows, your breast milk changes to meet the baby's changing nutritional needs. It contains antibodies that protect babies from infections, and breastfeeding also has many benefits for the mothers, including lower rates of diabetes and high blood pressure. Calorie needs will be higher while breastfeeding, as you'll need more food and nutrients to fuel milk production. It's encouraged to participate in at least 6 months of exclusive breastfeeding, as well as breastfeeding plus complementary foods for at least 1 year. When your baby is ready to begin eating solid foods, usually around 6 months of age, it's important to introduce new foods while continuing to breastfeed at first. This combo ensures that your growing infant will receive adequate nutrition until they're able to meet their needs through food alone. Nutrient needs for the mother are increased while breastfeeding, but nutrient needs are also increased postpartum for recovery for any mother, regardless of whether they're breastfeeding or not. Protein needs also increase for pregnancy and lactation. Strive to include a variety of protein-rich foods to ensure you're getting a good balance of all necessary nutrients. For example, seafood is the richest source of omega-3, while red meat is very high in iron. Additionally, aiming for the best quality proteins like grass-fed, pasture-raised, wild-caught ensures a higher nutritional profile and lower exposure to antibiotics, pesticides, and toxins. And just as calorie and protein needs increase, so do fluid needs. During pregnancy, you want to aim for 8 to 12 cups of fluid per day, and while breastfeeding, aim for up to 16 cups per day. Aim to drink fluids when feeling thirsty and finish one drink with each feeding to meet your needs. Weight gain is an inevitable and necessary part of the pregnancy process. Weight gain should be viewed as a good sign that your body is helping your baby to grow. Increases in weight are related to increases in amniotic fluid, blood supply, stored fat for feeding, the placenta, and of course, the baby itself. During your first trimester, you may gain only 1 to 5 pounds or no weight at all. And in your second and third trimesters, you may gain between a half a pound and 1 pound per week. While macronutrient needs increase slightly, micronutrient needs increase significantly during pregnancy. Folate is an especially important nutrient during this time as it helps prevent major birth defects of the baby's brain and spine called neural tube defects, and it supports the general growth and development of the baby and placenta. Folic acid is the form of the vitamin that's used in fortified foods and most dietary supplements. Folate is naturally present in a wide variety of foods. Many wheat cereals, breads, and pastas in the US are fortified or enriched with folic acid, but we have to remember a lot of times gluten-free products are not. Choline is another essential nutrient that you may be less familiar with. Choline is required for fetal brain development and placental function, and it also helps prevent neural tube defects. Despite the essential nature of choline, it's not included in all prenatal multivitamins, so a separate choline supplement may be warranted. During pregnancy, iron needs are higher than usual due to a massive increase in red blood cell production, as well as increased iron needs to support the growth of your baby and placenta. You should have your iron levels checked during pregnancy to check for anemia. It's important to recognize that animal sources are absorbed better than plant-based sources. Consuming omega-3 fatty acids is important for your baby's brain development before and after birth. Women should eat at least 2 to 3 servings of fish or shellfish, which is about 8 to 12 ounces per week, before getting pregnant, and while breastfeeding. There are 3 types of omega-3 fatty acids: ALA, DHA, and EPA. ALA is mostly found in plant oils, while DHA and EPA are mostly found in seafood. Calcium is important during pregnancy because it helps support your baby's rapidly developing bones, teeth, heart, muscles, and nerves. It's important that you're still maintaining your own calcium intake while you're supplying your baby. Ensuring adequate calcium intake while breastfeeding is also crucial, as your baby draws calcium from your breast milk, and if you don't consume enough, your body will pull from your own bone stores to meet the demand. This can impact your long-term bone density, which we know is already a concern for celiac disease. Vitamin D is essential in building baby's bones and teeth, as well as promoting healthy skin and eyes. If your provider hasn't already checked your vitamin D levels, request this lab test at your next visit. In practice, many of my patients have low vitamin D levels as they have limited exposure to sunlight and often need vitamin D supplementation. 600 IUs is likely the minimum needed, and many individuals may need higher doses. The ACOG recommends that all pregnant individuals take a prenatal multivitamin, which is specially formulated to meet the increasing micronutrient needs through pregnancy for both the pregnant individual and the baby. It's recommended to begin a prenatal as soon as you consider pregnancy to optimize nutrient levels prior to becoming pregnant. So we encourage patients to achieve good nutritional status and celiac disease remission before becoming pregnant to maximize the health of both the mother and the child. Because nutritional deficiencies can impact reproductive function, like Maureen mentioned, these nutrient levels should be normal or considered close enough by your physician prior to becoming pregnant. Generally, if you're following the gluten-free diet, we expect that you will heal and absorb your nutrients just like anyone else, and therefore nutrient recommendations are essentially the same. But we know that those with celiac are at risk for more deficiencies around when they're first diagnosed and also afterwards, as the gluten-free diet is more limited in nutrients compared to an unrestricted diet. Another reason why a gluten-free labeled prenatal is essential. If you're already deficient in a certain vitamin or mineral, you may require higher doses to meet your needs and replete your nutrient stores. We know many patients with celiac also experience lactose intolerance, which can make meeting calcium and vitamin D requirements more challenging and may require additional supplementation. Because of this, our team at Columbia published guidelines for micronutrient requirements and proper supplementation for those with celiac disease. Even if there are no deficiencies present, it still may be difficult to achieve optimal intake of certain nutrients on a gluten-free diet, so it's so important to review your diet with your dietitian. For those following a vegetarian diet, they'll need to be especially proactive to ensure adequate intake of all these nutrients. It's challenging to get enough iron on a vegetarian diet because of differences in absorption of plant-based iron sources versus animal-based sources. Make sure your prenatal contains iron as well as vitamin B12, which comes from primarily animal-based food sources. Eating walnuts, flax seeds, and chia seeds won't be sufficient to meet your baby's DHA needs, so for those who don't eat fish or seafood, an algae-based DHA supplement would be necessary. Include a minimum of 3 eggs per day or take a choline supplement. Regularly include seaweed in your diet as it's one of the richest sources of iodine aside from seafood. And for those who will eat dairy, eat plenty of it as it can provide several key nutrients. Pregnant women can get foodborne illness or food poisoning just like anyone else, but foodborne illness in a pregnant woman can be especially harmful for you and your baby. Certain foods are more likely to carry bacteria that cause foodborne illness. So to reduce the risk of exposure to various bacteria and parasites, you should avoid the following. Avoid things like raw fish and fish with high mercury levels. Be selective with smoked seafood. And some additional items to avoid include unpasteurized juice, cider, and milk, soft cheese and cheese made from unpasteurized milk, raw or undercooked eggs, pre-made meat or seafood salad, raw sprouts, raw or undercooked meat and poultry, and just remember to trust your nose. If it smells funny or you doubt the freshness or source of any food, simply don't eat it. There have been many studies on whether caffeine increases risk of miscarriage, but the results are unclear. Most experts believe that consuming less than 200 milligrams of caffeine or about 2 6-ounce cups of coffee per day during pregnancy is safe. They also recommend limiting to no more than 300 milligrams of caffeine per day while breastfeeding. Alcohol can harm your baby's health. It's best to stop drinking before you get pregnant. If you did have some alcohol before you knew you were pregnant, it most likely won't harm your baby, but the important thing is to stop drinking alcohol and stop smoking once you know you're pregnant. Pesticide exposure has been associated with impaired fertility and fetal development. You can't avoid exposure entirely, but you can take steps to minimize it. Here are some tips to limit your exposure. So you can buy organically grown produce or purchase direct from local farmers who don't use pesticides. Try to prioritize which produce you'll buy organic based on EWG's Dirty Dozen or for the food items that you eat the most. If you can't afford organic, it's still better to eat conventionally grown produce than to avoid non-organic produce. Local small farms often use fewer pesticides than large operations, even if they're not certified organic. And aim for pasture-raised meat, eggs, and dairy. BPA, most commonly found in plastics, is considered a hormone disruptor and has been linked to adverse fertility and perinatal outcomes, as well as impaired fetal and childhood development. There have been similar findings for phthalates and parabens, which are often found in plastics and cosmetics. Again, it's unrealistic to fully avoid any of these things, but we can do our best to minimize our exposure by avoiding heating food in plastic containers or in plastic wrap, like microwaving. Store food, especially hot food, in glass, ceramic, or stainless steel containers. Don't reuse plastic water bottles that are meant to be disposable. Try to buy fresh, frozen, or food that comes in glass jars. Look for phthalates in cleaners, perfumes, colognes, and cosmetics. And you can try to choose more natural products and limit added fragrance. You can use EWG's database to find some safe alternatives as well. Morning sickness or nausea or vomiting during pregnancy affects up to 70% of women in the first trimester of pregnancy, but tends to improve at around 14 weeks. To help with this, you want to avoid strong odors, eat small, frequent meals, and balance your blood sugar. Avoid letting yourself get too hungry or too full. Try salty, sour, or cold foods like hard candies or lemon drops. Avoid drinking too much liquid at one time. Try to sip on fluids throughout the day to ensure you're getting enough calories and hydration. Keep a snack like simple gluten-free crackers by your bedside and eat them before you get up. Try using C-bands, which apply pressure to an acupressure point on each wrist to relieve nausea. And consider supplementing with ginger or vitamin B6. 30 to 80% of women have heartburn at some point in their pregnancy. It occurs most often in the second and third trimesters as your baby pushes up on your stomach, which increases intra-abdominal pressure. Progesterone levels also increase, which relaxes the lower esophageal sphincter, and intestinal motility slows. Some tips to minimize your symptoms of reflux include wearing loose-fitting clothing, avoid overeating at meals, aim for those smaller, more frequent meals, wait 2 to 3 hours after eating before lying down, raise the head of your bed, practice good posture so there's more room for your stomach around the baby, minimize stress, and keep a food diary to help identify your trigger foods. Gestational diabetes, or GDM, is a form of carbohydrate intolerance first recognized during pregnancy, which usually resolves after delivery. About 8 to 10% of pregnant women in the US develop gestational diabetes. There are several risk factors, some of which include family history of type 2 diabetes, GDM in a previous pregnancy, and hormone disorders like PCOS, which I also have and led me to develop GDM during my pregnancy. In some cases of GDM, women are able to manage their blood sugar through a carbohydrate-controlled diet, and others need to incorporate insulin. With or without GDM, most women experience more insulin resistance in the morning, partly due to a surge in placental hormones and cortisol early in the day, and may need to choose smaller carb portions at breakfast. So I included some ideas for some carb-controlled breakfasts and some low-carb snacks and moderate carb snacks as well. Exercise is so important during this time. It's recommended to exercise 30 minutes or more every day. Exercise helps to lower blood sugar and blood pressure, prevent excess weight gain, and prevent larger than normal babies. It also reduces bloating, stretch marks, low back pain, constipation, and swelling in the legs and feet. It improves posture, muscle tone, and endurance. It boosts your mood, improves sleep, and decreases stress, anxiety, and depression. And lastly, it reduces postpartum weight retention and risk of pelvic prolapse. Self-care and stress management are vital as they support the physical and mental well-being of the mother and promote the healthy development of the baby. Here are some things to focus on: spending time outdoors, practice deep breathing, incorporate mindfulness, meditate, sleep, practice gratitude, and consider writing down a list daily in a journal. And although so much information focuses on pregnancy, do not underestimate the challenges of the fourth trimester. Prepare yourself as best as you can. Welcome support so you can rest, recover, and adjust. Reframe eating well as an act of self-care rather than a way to get your body back. Nourishing yourself with nutrient-dense foods rebuilds your strength and boosts the nutritional value of your breast milk. If you do plan to breastfeed, seek out professional support and lactation consultants. Stay on your prenatal supplements for at least the first 6 months postpartum to replenish your nutrient stores. Embrace a slow, mindful return to exercise. Consider meeting with a pelvic floor specialist. Be gentle with yourself and don't rush postpartum weight loss. It's okay that your body is different after having a baby. And in summary, it's important to stay positive, get enough sleep, eat a nutrient-dense diet, safely exercise, minimize stress, and be kind to yourself on your pregnancy journey. Thank you.
All right, thank you so much, Jessica. So I am going to get started with the cooking demo. So for quality reasons, we pre-recorded the video, but hopefully you can all hear my video once it plays. Let me know in the chat if you cannot hear the playing of the video.
Welcome to the kitchen. Thank you so much for those awesome presentations. I always learn so much from these culinary medicine webinars, but now I'm really excited to start cooking. Today we are making one of my all-time favorite recipes and really all-time favorite category of food, risotto. It's something that is so easy to make and can take so many different forms with just adding your favorite ingredients, whatever you have in the fridge. It really doesn't matter. You can toss it into the risotto and make a delicious dinner in not too much time at all. I'm also really excited that we have a live studio audience today. Some of my favorite people are here watching us cook. which is always a joy. These are some friends from our last celiac cruise, or many celiac cruises actually. They've been all over the world with us, and they were actually one of our big auction winners on this past cruise to appear in a Celiac Disease Foundation video. So they're here helping me today. So the risotto that we are going to make is a summer garden risotto. And what's really cool about this risotto is that we're going to start with making the base of a very generic risotto, and we're going to add vegetables that are growing fresh in the summer. You could be growing these in your backyard right now, or you can get them at a store throughout the year. Today, I decided to use shiitake mushrooms, corn, some sweet yellow corn, they're called Super Bomb grape tomatoes, and they're just so packed with flavor and just very, very, very sweet. And then, of course, zucchini. So before we get into adding in all the vegetables, let's start with the risotto base. So here in my pan, I'm heating up some butter and some olive oil. It's just starting to get warm now. The butter is already melted down. And to this, I'm going to add my arborio rice. So arborio rice is a very short grain rice, which means that it's very starchy. So we're going to add the arborio rice into the oil and butter, and we're going to coat it. So I'm going to stir the rice to make sure that it gets completely coated with the oil. Now, why do we coat it in oil? So this may seem like a silly practice. You know, when you're using a rice cooker, you just add water, you cook it until it steams, and then it's done. But for risotto, we don't want the rice to be mushy, and we're going to be cooking it for a really long time. We want it to actually be very, very creamy, but not stuck and clumpy together. And so by toasting it, we're going to get this really fragrant, nutty flavor to the rice, but we're also coating the grain so that it doesn't become mushy or stick together. All right, we also want to give this flavor. And so as we're toasting the rice, we're going to also put in some chopped up shallots. This is 2 chopped up shallots and some minced garlic. This is just going to give it lots and lots of flavor. We're adding it before we put in the liquid so that it has a chance to toast and brown and build out all those great flavors that are in these veggies. So we're just going to let these simmer for a few minutes until they just get slightly golden, and then we'll start adding in our liquid. So this has been cooking now for about 2 to 3 minutes, and if you could have smell vision, you would smell this beautiful toasty, garlicky dish coming up in front of us. It just smells so delightful. So I know that we're talking about pregnancy today, and typically we don't recommend drinking alcohol when pregnant, but we are going to deglaze this pan with a little bit of white wine. The alcohol does cook out, so when you eat the dish, you're not actually getting any alcohol from it, really just the flavor. So as it's deglazing, we're going to keep stirring so that nothing sticks to the bottom of the pan, and we're going to wait until the liquid is almost fully absorbed to start adding in our chicken broth. So we're going to add in increments here. So we don't want to add it all at once, or again, we're going to get that mushy, lumpy texture. And so we're going to add slowly, about 3/4 of a cup at a time, and wait for it to fully absorb before adding more. So we'll add them in. We're going to speed right through it so you can see what the result of all the liquid looks like, and then we'll get to adding our veggies and our amazing lemon basil flavor. Our risotto is still cooking here, absorbing up all that chicken stock, and I have my friend Robin here to chat with us. So I thought it would be really fun to talk about pregnancy cravings, since food during pregnancy there's so much about nutrition, as you've already heard, but there's also so much about the food that a pregnant woman just wants to eat. So Robin has a son with celiac disease. How old is Lewis?
16.
And he turned out okay, so you must have eaten pretty good during your pregnancy.
I tried.
So what did you want to eat when you were pregnant?
So most of the time I just wanted anything with carbs, but I got this strange craving midway through my pregnancy for hot dogs and lemonade. And I never really ate hot dogs, so I never know where that came from.
So when I was pregnant with both of my kids, all I wanted to eat were tacos and pizza, but like together, like not separately. And so I would like get a gluten-free pizza crust and I would spread the beans on there, put some grilled chicken and cheese and enchilada sauce, and it was so delicious. And
I think that should be the next recipe showcase.
Were there any foods that you couldn't stand that like you didn't want to eat when you were pregnant?
I would say really anything related to seafood or fish, I just could not stomach. And tomatoes, weirdly enough.
That's so
I was
sweet.
not interested in tomatoes at all. And coffee, actually, that's how I knew I was pregnant. I'm a coffee junkie, and all of a sudden, I just did not want coffee. I could not stomach the smell of coffee. And after, like, I don't know, 3 or 4 weeks, I finally figured out.
That was a little indicator.
Yeah, that was a little indicator.
Bacon.
Ooh.
I mean, I never really ate bacon anyway. Turkey bacon, yes, but I never really ate bacon. And I was like freshly pregnant and visiting a friend in California, and we went out to a restaurant where bacon was like very popular on the menu. So sick. Like I couldn't stand the smell of it the entire time I was pregnant. It's fine now.
Okay.
Delicious again, but
yes, I drink coffee again too.
but yeah, it's so interesting how these pregnancy cravings work.
Absolutely.
But how about nutrition? What did you eat that was, fulfilling and nutrient rich while you were pregnant?
So I really love to go for fruits. I was big on fruits. It always felt refreshing, especially through the summer and into the fall. Harvest kind of foods, pumpkin, all that. That was really my go-to. I would say I struggled a little bit with getting adequate protein. That was definitely my struggle because I really just wanted fruits and starches.
Yeah. How about exercise?
Exercise, I was really proud of myself. I would swim all the time and I would run. And I swam all the way in an unheated pool all the way through into the beginning of February. And he was born the 3rd week in February.
We definitely share that. Exercise was so important to me. I think I exercised up until the day I went to give birth.
Yeah.
And I do think it really helps, keep you motivated, keep you moving.
Yeah, I did as much walking as I could. And swimming. Walking and swimming were my go-tos.
So, Robin, I have a very important job for you. Would you mind stirring the risotto? This is very, very, very critical. If we stop stirring the risotto, it will stick. And so we want to make sure that that doesn't happen. So I will hand the spoon to you, and I'm going to start making our mascarpone mix-in that we're going to add. So in the food processor here, I have a full bunch of basil. I have about a half a cup of mascarpone cheese, some Parmesan cheese, and a little bit of salt. And to this, I am going to add lemon zest. Now, all of the ingredients in here are very important in pregnancy. So even though we talk about health and nutrition, it is very important that when we're pregnant that we're still getting dairy and fat into our diets. These are important for the baby to be growing and gaining weight and for mom as well. Also, lemons. Lemons are packed with vitamin C, and this is an essential nutrient when you're pregnant. So we are going to take the zest off of this lemon and add it to the food processor. This is going to give our risotto some amazing flavor, not too tart or citrusy, but just enough little bit of a zing to make it absolutely delicious. Now you could do this on a cutting board. You could just chop everything up and stir it all together. I like to do it in a mini food processor so that it's finer and more chopped up all together, but it really doesn't matter. If you like it chunky, you can do it just chopped with a knife. It's really your call. All right, I'm gonna do a second lemon. I think that just smells so delicious that a little extra zest never hurt anybody. So we're gonna do a little bit extra today. You can also add any herbs that you like. I love basil, and especially in the summer, it's such a great addition to your risotto, but you could also put it in a salad with watermelon and feta cheese, with fresh mozzarella and tomatoes. There's so many different ways that you can use basil. But if you prefer parsley or oregano, you can really pick the herb that you want to put into this dish to make it your own. Now we are going to put the top on and mix it all up. This is what the product looks like after we pureed it all together. this is really, really thick. And so I want to thin it out just a little bit. And so I'm going to stick with the natural flavors of what's already going into the dish. And I'm going to put a little bit of the lemon juice right into here just to thin it out a little bit. The risotto is ready. It is soft and tender, and it is ready for us to add in all of these amazing veggies. So I just turned the heat down a little bit. We're going to start with the mushrooms. These are some shiitake mushrooms. You go ahead and stir those in. I'll add just a hair more liquid, only because we're using an electric skillet and it's a little bit harder to control the speed of cooking. So this will just help us keep everything a little bit moist. This risotto is great for pregnancy because it is packed with veggies that are very high in folate. Folate is a really important nutrient when you're pregnant because it helps the baby develop strong neural tubes. And so we want to make sure we get lots of it in our diet. Corn is packed with folate, as is zucchini. So we're going to add in some corn, all of that in there. And this is about 2 shredded zucchini. I just used a box grater to shred it up. So we'll get that all nice and stirred in. Good job, Robin. Is this the hardest you've had to work in the kitchen all week?
Seriously, yeah. After that cruise, definitely.
So Robin and I just came back from Celiac Cruise, which was quite an amazing experience. We got to eat so many delicious products. Lots that were from Shar as well. Thank you again to Shar for sponsoring this webinar. And it was really nice to have, somebody else cook all the gluten-free food for us during the week.
100%. We just got to enjoy.
So now we're just cooking this enough to get the vegetables soft. One of the things that is really important for me in making a summer dish is that the vegetables aren't cooked down too much to where they've lost their structure or they've lost the integrity of it right off the vine. I love picking veggies and eating them fresh out of the garden. And I want to make sure that when we sit down to eat this risotto, that we're still getting that experience, but we're cooking them enough to bring out flavor. So we're actually going to add in the tomatoes last because tomatoes cook down really fast. Think about making a marinara sauce for your pasta. Those tomatoes cook extremely fast. And so we don't want to put them in until the very end so that they still have a crunch to them when we actually sit down to eat our risotto. So we are going to add in our basil mascarpone mixture. Robin thought she was going to get kicked out of the kitchen, but I'm going to make her keep working. So this has salt in it already from the Parmesan cheese and a little bit of pink sea salt that we added in. So we may not need to add any additional salt to this dish at all, but we'll taste it to decide right before we serve it. I can't wait for the day when we get smell vision on webinar. That'll definitely make a really big difference.
It's going to happen soon, I'm sure.
So now I made a very big pot of risotto today. I've actually doubled the recipe from what's in the recipe cards that you were given because Robin and her very hungry son are here. He's here for a hockey tournament. And so we got to make sure to feed Lewis a nice big hearty dinner. So I did make a double batch. So if you're making it for a big family dinner, it's very easy to double the recipe. Just use a bigger pot. I think we're ready to add these tomatoes in. We'll give it some beautiful color. Just gently stir those in, Robin, and you'll get to take the first bite.
Oh my goodness.
I'll trade you spoons.
Okay.
And let's give her a taste. Cheers.
Cheers.
Good.
That's incredible.
Really good.
Oh my gosh.
Well, thank you for helping me in the kitchen today, Robin.
Yeah.
I hope you've all enjoyed today's cooking demo and that you're all going to go tonight and make this amazing summer garden risotto. So I'll toss it back to our speakers for our Q&A.
Great. All right. So for those of you who are looking to make this delicious recipe, here is the ingredients list, and you can scan this QR code in order to access it on our site, and we'll also share it in the chat. Okay. All right. So just before we wrap up and start the Q&A, I am going to ask the participants who are, especially the healthcare providers, in order to claim your CEU certificate, we will need you to fill out a post-event survey. So the healthcare provider link is here. Also, for patients and caregivers, your feedback helps us determine the content of these webinars moving forward. So if you enjoyed this presentation or have feedback on this presentation, please follow that link and fill out that short survey. We'll also share these links in the chat. Okay, and I will leave this up for a couple of minutes because for healthcare providers, the process for getting your CEUs is a little bit more involved than it has been in the past. So if you've been to the last 3 webinars, the process is the same, but Boston Children's Hospital provides the continuing education credits for these culinary medicine webinars, and you will need to log into their website and type in this code P8BKE in order to get credit. So the best way to do it is to text with your phone, and then you'll have to log into the Boston Children's Hospital website to claim your continuing education credit. So I'll leave this up for a couple of minutes just so that everyone who needs to claim their credit can do so. And then I will ask the speakers to come back on because we have so many questions. So we will do our best to get to as many as we can, but we are going to wrap at 4 o'clock. All right, I guess I'll just start from the top. Any evidence of a link between preeclampsia and celiac disease?
So there has been a large sort of meta-analysis that did not find a link between preeclampsia and celiac disease. Other smaller studies have, but the major one did not.
Thank you. We got a lot of questions along these lines. If the mother who is breastfeeding is on a gluten-free diet, will the gluten antigens still be passed through her breast milk? Now, Maureen, I know you addressed that, but can you reiterate it?
Yes, so if a mom is on a gluten-free diet, then there shouldn't be any gluten in her system, and so none would pass through the breast milk. And I think something came up. We don't know what that means for the risk of celiac disease. There hasn't been work looking at whether the amount, whether it's passed in breast milk or not, will influence later celiac disease onset. That paper just came out within the last year, so more work to be done there.
Great, thank you. Does following a gluten-free diet remove or reduce the risk for malabsorption, or is that an ongoing concern for someone 10 years later after starting a gluten-free diet?
You want me to answer? It shouldn't be if you are healing, but obviously that's why follow-up is so important with your doctor and your dietitian to ensure that your labs have normalized and your intestines are healing. So there shouldn't be if you are being treated appropriately, but it's obviously possible, and that's a reason to follow up.
Okay, we have a couple of questions. In the interest of time, I'm going to combine them about accidental gluten exposure. Emma's writing, does anyone have advice? I was just diagnosed with celiac disease at 14 weeks pregnant, and I'm worried how this will have impacted my baby. And then we have another question about, if accidental gluten exposure can affect the baby's development. So I think they're kind of related. I don't know which one of you wants to take that.
I can start. Well, I'm so sorry to hear you were just diagnosed at 14 weeks. That's got to be so tough. But at the same time, that's great news that you were diagnosed now and you can start the gluten-free diet and get your intestines healing. So I think that's good news. And hopefully you've connected with a team near you that can help ensure you're on a gluten-free diet, because that's the most important thing, is starting your gluten-free diet and taking your multivitamin. I think there was a question also about accidental gluten exposure, and I think that shouldn't necessarily, or we don't have evidence to say that that would affect an infant's development. Certainly, if you have celiac disease and you have gluten exposure and you're breastfeeding, it may affect your milk supply depending on your symptoms. So if you have vomiting and diarrhea and you're dehydrated, you may have a hopefully just transient reduction in your milk supply if you're breastfeeding.
Thank you. Okay, there's a question in here about actually fathers. And I think it's an interesting one that we might not have a lot of research about. But does a man who doesn't have celiac disease have to, how does he have to prepare his body to produce healthy sperm? Um, if the father has celiac disease or not. Do you have any information here?
Yeah, I can take that one. So, I think that a lot of the focus is on females for pregnancy and fertility, but really male fertility is important too, and following a healthy lifestyle and incorporating some of these same practices for the males is really important, whether it's celiac disease or not. So you can optimize your fertility in the same ways that we talked about today. So I think that it's a team effort in that.
Great. Um, okay, and then, there are a lot of questions we weren't able to address today, but I do want to just end with one about, what specific things should someone on their fertility journey be speaking with their doctor about if they have celiac disease? I know, like, all of you have experienced this at some point, so just any advice we could close on that.
I guess, in terms of what I had talked about in my talk is just following up to find out where your nutrients are at. So we obviously want your nutrients to be as optimized as possible and not to freak out if they're not, just talking with your doctor and your dietitian about how you can optimize them through food and proper supplementation. And obviously, if you're diagnosed while pregnant, you do the best that you can in following a gluten-free diet and practice. I am a little bit more conservative in not taking risks during this time in terms of following a gluten-free diet, but also not to stress out if there is accidental gluten exposure. Of course, anyone with celiac disease knows that you can't 100% prevent anything for your whole life. So just as it's 9, 10 months of your life, things can potentially happen. So really just being on top of checking your nutrient labs, getting proper supplementation, following up with your doctor and dietitian to review your diet to optimize your intake.
I'll just add that pregnancy is a time when our bodies crave weird things. And I know that when I was pregnant with celiac disease, I wanted a Pop-Tart so badly. And as we all know, Pop-Tarts are not easily accessible for people who need them to be gluten-free. And no matter how many I tried in the gluten-free world, none of them kind of hit the spot like I remembered a regular Pop-Tart would. And it can be frustrating when you really, really want something and you can't get that specific food in the way that you want. But like Jessica just said, it's a short period of time. And, that's why there are really great dietitians out there like Jessica and Megan and many across the country who can work with you on your diet and looking for things that are safe for your gluten-free diet that may also meet your craving needs. But don't give in to them if they're not gluten-free.
I also think anyone with celiac disease is kind of a pro in understanding dietary restrictions. So once you're given some of the pregnancy dietary restrictions and realize, oh, this is only for 9, 10 months compared to my entire life, it may not feel as daunting, but obviously it's on top of each other, so that can make things a little bit more complicated.
And I'll just add to give yourself grace and do your best, but know that a lot of this is out of your control. So studying the microbiome, I had to have a C-section, and that was, completely out of my control. So just, again, aim for your best, but know that a lot of this is out of your control.
Okay, and that is all great advice. Thank you to our speakers. For everyone who attended this webinar, there is going to be a recording available. The link is in the chat, but we will also share it after the webinar. So thank you for joining us today, and catch us next time at our October 15th webinar on follow-up care. The link to sign up is here. Thank you.